All right. Well, thank you everybody for joining today in this session. And apologies, what I'm going to do is mute the source of that chiming in the background there, hopefully. Clear it out. All right. Thanks everyone for joining. My name is John Fraunfelter. I hope you all can hear me, and this is a roundtable, so it's a discussion. I have some slides to spark the conversation, and to make it a more engaging roundtable, first I would encourage you, unless you're incredibly shy or having a bad hair day, please feel free to share your video. I'd like to make it as interactive as possible, and thank you, Felicia and Jamie, you're on video. I will appreciate interruptions and questions, and I will not talk the whole time. So I'm going to be starting a conversation around what artificial intelligence in clinical care and healthcare is doing right now in healthcare in general, more broadly. And then I want to learn from you all, as I am not in the correctional space. I'm a physician, and I'll introduce myself in a moment, but I want to learn from you all how this sort of level of analytics and insights could be applied to the correctional setting. So I really appreciate your expertise and time, and hopefully we can all learn from each other on this call. So I'll start with introductions, and then I would ask for folks to also respond with a one-line introduction, and then also I'm going to ask you to answer this question if there's one thing you'd like to take away from this roundtable or session today. I'll make a note of that and see if we can make sure we cover that, assuming it's relevant. So I'll start with myself. My name is John Fraunfelter. I'm an internist, and I'm Chief Medical Officer with Jvion. Jvion is an artificial intelligence company dedicated to healthcare, and I'll be getting into the specifics of what we do and what's happening in the healthcare space. And my journey, I've been in healthcare, trained and grew in the Detroit market back in the 90s. I've got, looks like Jamie, you might have a bandwidth issue because you were breaking up a little bit too. I want to ask, can everybody hear me okay? Can anybody hear me? All right, I see a thumbs up. Excellent, thank you. All right, so excellent. You guys are giving the thumbs up. Feel free to engage. Again, feel free to put on your video, answer audibly. I want to have a good discussion here. I trained in the Detroit market back in the 90s, internal medicine and pediatrics, and then taught academic medicine, ended up in health, IT leadership in several different organizations, and fast forward 20 years, ultimately I've been with Jvion as an artificial intelligence company in healthcare for the last 5+ years. I'm going to ask for people to give just a one-line introduction, where you're from, and what interests you about this topic, or if you've got a burning question you'd love to have answered. And I'll just go around the horn, and if you're not able to respond or the audio's not working, that's fine. I'm going to start from the top of my screen, and I'm going to mispronounce some names. I see Mashikia, and if you can hear me.
Yes, that is correct. You pronounced it correct.
Oh, good. Thank you.
I am a registered nurse. I've been in healthcare now for 26 years. I am with WellPath Correctional Facility, and I have been in actually corrections for less than a year, but I'm a nurse, have a doctorate in nursing, and I've been, my background is quality and safety. Excellent. And so I'm always looking to learn about how to be very innovative in care delivery. It doesn't matter the setting, corrections or acute care.
Fantastic. Next to my screen, I see Felicia.
Hi, I am a person who can't stop working. I actually retired in 2017 from the public behavioral health system, and now I work as a consultant. I helped a community services board establish MAT at a county jail, in a county jail setting and a CIT program in their community. So now I just can't stop working, although it's a goal.
Well, fantastic. Thank you for joining. And then I have Quinn next on the upper right there on my screen.
Hey, how's it going? Quinn, Alaska DOC, 30 years as a nurse, but only 6 weeks in corrections. Lots of experience with informatics and using artificial intelligence engines in acute care hospitals. So I'm curious to see what could we do with it in corrections.
Fantastic. And I have Marianne.
Hi, I'm Marianne Curl. I'm an internist and geriatrician. I've been working in corrections for 1 year and worked for the VA prior to that for 2 decades. And am just interested in how we can improve the lot of the incarcerated patients by being smarter about how we deliver healthcare. And I think this may be the key, to getting a grasp on what we don't know about our patients a little bit, and mining what we can know. Excellent. And anticipate their needs.
And I have to say, Marianne, not that I was scarred, but my first month of internship, I was in the VA in Detroit area in Allen Park, where the air conditioning system was blowing cold air down the hallways. Those were 95-degree summer days. So remember it well, like yesterday. And next I have, and I am not going to get your name right because the letter, Meflaguer. And you're muted. If you're able to share with us just introduce yourself and any burning questions or interests you have.
I'm Mary Beth Fleegera. I'm with Washington Department of Corrections, Washington State Department of Corrections, and I'm part of the Health Services Quality Team. And we are still working with a paper-based medical record. And so we are looking for all kinds of creative, innovative ways to benefit our patients while we wait for the legislature to give us funding to get an EHR.
Thank you. Leanza? And Leanza was giving me affirmations in the text and whatnot, but I haven't heard you speak yet, so I'm not sure if you're able to, if you've got the audio going or not. All right. We'll go ahead on, and we can always come back if you get that working. Shauna? All right. On to, I have Patricia in the lower left here.
Sorry, this is Shauna. I finally got the unmute to unmute. Hello, I am in a government agency, and I'm just very much interested in looking at how AI applies in this setting and what more we can do to be smarter and mine data.
Excellent, thank you, Shauna. And Leanza, I see your comment here. Fire questions in the chat or text. Again, my goal is for this to be interactive. I have some slides about what Jvion is doing in healthcare. Is not a commercial. It is to stimulate conversation and discussion. And we'll get into those in just a moment. I'm just interested to learn perspectives here. This is very valuable for me. And then Patricia, have you got your audio going? Okay.
How are you?
Oh, wonderful. Okay, so introduce yourself and any burning questions or interest.
Yes, I too retired from my first stint with corrections in Montgomery County, Maryland, as Director of Mental Health, and came back from retirement 4 years ago to another facility. So I am very interested in anything that's innovative that helps us identify high risk, the high risk population. I just want to learn about artificial intelligence in the healthcare field.
Excellent. And Melissa?
Hello, my name's Melissa. I'm a social worker from Edmonton, Alberta, Canada. And I am actually just here to kind of see what's going on in the States and how we're doing things differently and maybe how we can do things a bit better up here.
Wonderful. Aaliyah?
Yeah, hi, this is Aaliyah Moore. I'm an internist. I work at the Los Angeles County Jail. I've been there for about 4 years now. I'm mostly interested in the cost associated with this kind of technology and the learning curve, because I find that, especially in corrections, because a lot of times we're slow in the upkeep of things like EMR, there's a lot of unfamiliarity with how to utilize this sort of stuff.
Excellent. Yes. And then I have Kimberly, and I'm not sure if you were able to go on audio, Kimberly.
Hello, sorry, I did not anticipate the time change. I'm in Virginia, so I just got out of the parent pickup picking up my children. I am a nurse practitioner and I work in Virginia in a prison where we house involuntarily committed inmates that require mental health treatment. So I'm primarily interested in this course specifically because as someone else had stated, we are very behind in our technology. We still have paper charting and so forth. So this is something that sparked interest.
Excellent. And Leanza, I see your hand up. Did you have something there is that on purpose? You have something to shoot a question to us? Or it might have been an accident, misfire. All right. Last I have is Jeanette.
Hi, I'm with Illinois Department of Corrections as the agency medical coordinator. We are in the process of looking for anything, basically EMR and anything that will increase efficiency for our healthcare units at the state, at the different facilities statewide. We did have an EMR vendor previously. That didn't work out. We had to back out. So now we're in search of another one. So I'm just trying to see what is out there that would help. It doesn't have to be an EMR. It could just be anything that improves efficiency in communication, documentation, data analysis, and all that.
Excellent. And Leanza, are you able to go on audio? Did you have a question or text it in if you can't? All right. And then looks like Michelle is back. Michelle, if you're able to introduce yourself, go ahead and then we'll jump into some slides here. Okay, well, on that note, I'm going to share my screen, move through some slides pretty quickly, but not deep, because it'd be easy to just bury folks with information, and I don't want to do that. So sharing my desktop here. And you should be able to see a slide deck that says a clinical AI that moves you from predictive to prescriptive intelligence. And I'll trust somebody give me a thumbs up or
looks good.
High five. All right, thanks. I'm going to take a chance here going to presentation mode. Sometimes going into presentation mode makes everything go slower or crash altogether. So hold your breath. And I have 30 slides. I'm not going to go through all 30. What I'd like to do, review, just high level, I did a little bit of research. Obviously a lot of challenges that I heard even in the introductions. Brief overview of clinical AI, what it is, what it isn't. And then what we're doing in healthcare with AI. And then our discussion will be perhaps some challenges and how clinical AI could be applied in the care of vulnerable individuals in the correctional population. So we've covered introductions, and I'm going to move on here. Some of the searching I did on the government websites and whatnot These are probably statistics you are either intimately familiar with or saw a dozen times already in the last day, so I apologize if it's redundant, but a whole lot of people in federal and state prisons, 1.4 million folks. And then in local jails, an average of another 734,000 with a rapid turnover. That's a whole lot more people in any given year that are jailed temporarily. And then I identified and kind of teased it apart a little bit. Recidivism is also a significant problem that within a person being released, 67% are arrested for a new crime, which was to me shocking. And then within 5 years, 76% are rearrested. And then there was more statistics around that. A lot of those people are in the first 6 months after release. And there's a trend towards the younger age group. There is some sense that you actually outgrow behaving in this way, or either that or you get smarter and there's a better chance of not getting caught. In any case, there's a pattern around recidivism. And so you begin to ask a question like this: are there ways to leverage artificial intelligence to better understand the prison population, to understand, for example, who's likely to end up committing another crime, who's likely to do well out in the community versus who's likely to do poorly, or what are some of the factors that would drive that? What can be done about it? Would analytics insights be beneficial to understand and better care for the population? This is a type of question that brings these conversations together between a large population and some challenges around them and what's happening in the rest, not only in healthcare, but in general. Now, with that as context, I'm going to talk through analytics maturity for just a moment here. And you get, at the most basic form, you have raw data, and then it's, when we say cleaned, it means it's been normalized or errors have been identified and removed, and so that you could get some understanding of what that data means. And that's the basis for creating standardized reports. And then as you get a little more sophisticated with analytics, you can say, oh, I want to ask this question, and you get an ad hoc reporter, or digging into a different population, or asking a different clinical or another variable question around that population. Who are all the patients who are in with substance abuse, or who are all the patients who are in for property crimes, or that sort of thing. And so that's reporting. Now, predictive analytics gets a little bit more deep. So we're going from data to information, now to knowledge, to say, so why did it happen? What's the pattern, and how do I interpret that? So you can begin to get some interpretation of why is there such a high crime rate in this particular area, for example, in this particular geography. What's happening, or what changed? And is there a correlation with police presence, or with increase in social programs, et cetera? And then predictive modeling is forward. This is the first, now that darker blue circle, it's forward looking, saying what will happen. And this would be where we could say, of all the patients, again, as a physician, I think in terms like that, of all the inmates or persons who are being released, who are the ones that are likely to have challenges when they go back out in society, whether it's to struggle from a socioeconomic standpoint, or mental health, or going back into some crime perhaps. And then ultimately, in this optimization is the highest level. This would be what we would call on this scale. Again, you've got data, intelligence, and then knowledge, and then wisdom. Wisdom is the highest order in some analytics models. So, and here it says optimization, what is the best that could happen? All right. So if anybody's familiar with Maslow's hierarchy, where the lowest level is I need my basic, food, heat, and shelter. And then as you get more and more sophisticated, we have our social needs met and emotional needs met, and driving to ambition and those sorts of things. So when you convert that to a data, Maslow's hierarchy of data, this is just an interesting look at getting the most basic data sources available, and then getting the data flow reliably, and then beginning to trust the data by cleaning it, identifying anomalies in the data where it's maybe there's an error, you don't trust it. So beginning to trust the data is this layer here. And then now I begin to do reports or analytics and begin to see retrospectively what's happened and to understand how we're doing. So retrospective reports are really status, you could say status reports to understand how we're doing. And then these last two are about, again, about the future, what's going to happen. And then AI and deep learning is the most sophisticated in terms of data science. And also, again, tying back to the previous slide, that's what is the best thing to do to modify what's going to happen. So one last slide on this, just to reinforce this. I'm not sure where everybody's at, so I apologize if this is redundant, but if you think about it, this is a simple way to remember it. And this is from Gartner. When you have the most basic answers to questions, descriptive analytics is what happened. And then you get a little bit more sophisticated, some deeper diving into why did it happen. Predictive modeling, predictive analytics is what will happen. And again, another term for that would be risk stratification, identifying patients or inmates at risk. So predictive analytics is really just stratifying patients on a scale from high to low if it's patients at the center of the question. And then lastly, again, and this is on that other scale I described, it's wisdom. From a clinical standpoint, this is clinical prescriptive analytics. How can we make it happen? So if we want to modify the risk for somebody in order for a better outcome to occur, this is the level to which we're getting from an analytic standpoint. This does require artificial intelligence to be working. This requires more sophisticated modeling than simply predictive analytics and the more basic algorithms that can be built by data scientists. This is the most sophisticated level from a category standpoint. All right, I'll pause there before we move on. Well, one more slide and then I'll pause. I don't know if anybody would disagree with this. I'm going to come out and make a bold statement. Healthcare is behind when it comes to analytics. That might shock some of you. But when you think about Amazon can predict you're going to want a pair of shoes or you're going to buy a garden hose in the next 6 months, and then they push advertising to you to help make that happen. They're pretty sophisticated. They manage warehouses in a predictive manner so that they know they're going to need more supply over here than over there. And that's combination. That's not just predictive modeling. It is also machine learning. If anybody ever watched the movie Moneyball, that's older now, 10, 15 years ago. They started doing predictive modeling for baseball, and which players are going to perform the best in which scenario. Weather forecasting, heavily reliance on machine learning, although hopefully they can do better than 50% accuracy sometime in the future. But even things like predicting civil unrest with a 7-day lead time, it's pretty surprising, but this is the sort of sophisticated analytics being done in other countries by some reading that I've done, and so on. So healthcare is behind. We're having a hard time predicting who's going to have a complication to an illness like diabetic, who's going to get sicker, which socioeconomic factors are driving risk in this particular patient. Would they benefit more from Meals on Wheels and getting food delivered to them, or would they benefit more from transportation? These are seemingly simple questions, but we have a hard time getting to the answers of this sort of thing. So I'll pause there before we get into a little bit more specifics of what Jvion's doing. Any thoughts or reactions so far around this kind of an overview of artificial intelligence and where we are in healthcare? And then I'm going to share specifically some of what Jvion's done in healthcare space to make it a little sharper. But I'll pause there. Any questions, comments, reaction from the group? All right, and I see it looks like some comments here in the chat. I'm going to try and open this up here. I see Michelle's comments there. Thank you. Thank you, Quinn. Quinn agrees that we are way behind. So yes, and the pandemic exposed a lot of both challenges, we'll say opportunities in terms of how things can be done better. So a little bit about Jvion. We're one of the market leaders in AI healthcare. I'm not going to go through all our awards and bore you with that. We've helped a lot of different health systems and also in the payer space in the last few years. Also AI is coming into its own. So artificial intelligence a couple of years ago was novel. It was what they call the bright, shiny object. Now it is, I think we're moving to the point where people are recognizing it is absolutely necessary. A lot of shops are doing their own work with machine learning and AI to ask and answer really sophisticated questions. So it's an exciting time in healthcare. I'm going to highlight 3 points here. And I mentioned risk stratification. And one of the things that Jvion does is identify patients at risk. So identify patients on a path towards that negative outcome that we're trying to prevent. Now, if it was predictive analytics, that's where it would stop. But with prescriptive analytics, we can ask and answer the next question, which is why are they at risk? Like what's driving that risk? And this is one of the things around this concept of a black box with AI is, well, you're telling me this, but tell me why. And so one of the things we answer is why is that patient at risk? And some of the factors are socioeconomic, some are clinical, and a combination of the two. And then the third element that we deliver is specific interventions that are patient specific. So what are the things I can do to change the outcome for this patient? So those are the 3 things that our solution does. And I'm not going to spend much time on this slide. This is a slide we love to talk about and admire ourselves. But the bottom line is we have sophisticated data science and a holistic look at patients to understand more than 4,500 or 5,000 features about every single patient. Many of them are inferred or what we say imputed to the patient. And then many are data that we purchase or are captured from clinical data that we get from our customers. So when we have that holistic view of a patient, that's the starting point. Then we also have clinical outcomes in our data universe, and we can say this patient's headed towards that outcome where that cluster of patients sits, and it's preventable. And so that's just a taste of how the machine learning works. We have a whole bunch of use cases. I've bolded some of the ones that might be more interesting in the correctional setting. You can see a lot of these are related to behavior and perspective, perception, depression, medication adherence, risk for opioid abuse, patients not showing up for their visit. So these are clinical. These are not specific to the correctional setting, but they might be of interest or relevance in that setting. And so we have, as you can see here, this is a representative sample, but dozens of use cases asking and answering these questions because we've developed this over the last 10 years. Now, how does AI get to this level of value or sophistication? It requires the right data sources. And so when we talk about data sources, this is clinical data, claims and billing data, might be registry data, or data from another system where the case managers, care navigators are working, or enrollment data if they're in a health plan. And then all this down the side here is socioeconomic data. And these are data sources. And again, anybody can get the data sources if they have money and time and expertise. But to combine these in a way to turn data and interpret it correctly into intelligence is the hard part. So these are some of the data sources though, and that's where it starts, is taking these data sources and combining the data using the machine learning. When you do that and you understand what the data means, and then you apply it to patients, and then you get the output that I've described earlier, which is not only risk stratification, but also why they're at risk, and then the reasons or the things that we can do to help that patient. So This is just a touch about Jvion. I'm going to get in now specifically to social determinants of health. And during COVID, we used our insights around socioeconomic data to create a publicly available COVID vulnerability map. And you can still go to the website. I don't have it memorized offhand. I think it's covid19.com. And that might not be, you could, if somebody's bored, you can go look for it right now. But I think that's the website, but I could be wrong. It's been hit over 1 million times. Obviously, COVID was pretty much attention getting for the last 15 months. What this shows, if you look at this map here, is the areas of dark purple are highest risk and vulnerability. And these are not zip codes. This is down to the block level when it zooms in. As you can see here, this is zoomed in now. Here's the streets in this block. And in this case, you can see, and this is actually from Detroit, this area is fairly low risk relatively, except for this spot here. And when we looked into why is this area so high risk, there's an a senior living center in this area that was right in the center of that purple area. And so we didn't have an algorithm that said, well, if there's a senior living center, then highlight it purple. What we had was enough socioeconomic data at the neighborhood and the block level, and in some cases even the person level, that we said there is an area of risk, and it rolls up so that it's purple on the map. This data that we have behind these maps have been used by FEMA, CDC, the Atlanta Food Bank, and numerous other local and state municipalities as well. So, and we got some press for it, which is nothing more than my point to establish credibility with you that we can use this data to identify risk and actually then help vulnerable populations. And that's kind of the point. We've also published an article demonstrating the ability, again, with just socioeconomic data to predict outcomes. In this case, the outcomes were related to ending up in the emergency department or ending up in the hospital as a hospitalized patient. And this was using only socioeconomic data, not having any insight whether a patient was diabetic or had heart failure or anything else. And so this was published a year ago. When we talk about social determinants, there are two ways to do it. Oftentimes, a typical approach today is, okay, well, the zip code has challenges around employment access and also food access. They're in a food desert. And because of those features, then we attribute those features to everybody in that zip code. So that's what we call a top-down approach, that, well, because it's true on average of this community, then it must be true of everybody in the community. And we know that that's patently untrue. It's just, if you don't have alternatives, that's the best you can do, is attribute every feature of that average population to every individual. So the bottom-up approach says, if we understand individuals, then it rolls up to an average for that population, and then those populations roll up to an average for the community. So we start with the individual and work our way up so that the average is reflected by the individuals, but each individual has their own features and unique aspects that matter to them that we understand at that level. So this is an example. If you look at the category of socioeconomic factors that drive risk, and this is in the community setting, but if you look at the factors that drive risk, I never would have expected air quality to be the very top in the list. I would have expected it to be higher, but this one, in terms of good air quality, is a modifier for risk, as well as obviously bad air quality. And then the others in the list here are demonstrated. I want to touch on one other point real quick around bias. Our approach, we do evaluate for the risk for bias and understand through the machine learning and the data science. We test, and it's data science techniques that I won't get into here, but we test to see if there's bias in the model. One of the things we learned is, if you look at the bottom here, age and race and gender, age actually ranks pretty high on the list. I'll come back to that, but race and gender were fairly low in terms of their unique drivers of risk. What this tells us is that we were able to identify the other features of patients that really were the drivers when we talk about their primary language is or isn't English, or they have access to retail stores, education level, financial security. These are the drivers here. Now, age was much closer to the top. The reason why in the socioeconomic study, why age was closer to the top is because we didn't have the clinical data, but we know the older a person is, an 8-year-old is going to have on average a lot more clinical conditions, chronic diseases than a 30-year-old. And so age was a marker for chronic conditions here, and that's why it pushed to the top. But if we actually have the chronic conditions, that too would wash out. So I'll pause here. Any questions, comments? And I'm going to check the chat again here. And Jeanette's asking a question of the basis for the criteria high risk. Can the user change that? And then, so when we define, if you're asking about how we represent risk and we classify patients as high, medium, or low risk, those are cutoffs that can be adjusted based upon, you could set the setting for high risk at the top 10%, for example, in a model. There's this concept called cutoffs. And you say, well, on 1,000 patients, or let's say 100,000 patients, we can only manage going after the top 1,000. Well, then we might set a cutoff at very high risk to capture the top 1,000 out of those 100,000 so that you can go after that top slice. And if you said, actually, we can do some automated outreach and contacting or calling to 20,000 out of that 100,000 patients, then we might move high risk a little more generously than just the top 10% to maybe the top 15 or 20%. So a cutoff is a sliding scale that you have to at some point lock it in and say, this is where a cutoff's going to be for high risk, but it is adjustable. The model performance is assessed first, and then risk stratification of high, medium, and low can be assigned. And those are general approaches to when you're doing risk stratification and predictive modeling. And then Felicia asked a question, define the term neighborhood in migration. And what that is recently having moved into a neighborhood, essentially. They've recently moved, and as a result of recently moved, they might have less social support. They may not have not only people that they know, but also resources. Like, I'm not sure where the grocery store is, or where's the local library or whatever else. Starbucks, probably the most important thing, right? So the access to typical resources, your social support, bus schedules, if you ride the bus, that sort of thing, especially in big cities, nobody has cars, they ride the public transportation. All these things are variables that drive risk in somebody who's just moved into a neighborhood. All right, so I'm going to keep going here. In fact, again, the reason I'm going through these slides is to stimulate thinking. So I'm going to cover 2 more slides, and then I'm really going to pause. We've developed what's called a social vulnerability index, and so we rank patients in terms of overall risk based upon the insights that we have on those patients, along with when we get name and address, maybe registry data, also any clinical data that we have on that individual as well. But this is an emphasis and a focus on the social vulnerabilities around that patient. So what we do, and again, this is all with the same data science, and we get a name and address identifying information, and then we can tell the provider, the health system, whoever's working with this population, not just here's a neighborhood where you could benefit from investing in a food bank, but actually these are the individuals within that neighborhood who have the greatest risk for food access. And so you're getting down to the individual risks, and you can address and mitigate risk at that person level. So if you've got social programs that you're providing to a community, then in that setting, you do it in a neighborhood, but then you also might target individuals to say, hey, can we support you in this way? And doing some personal outreach like that. And then many health systems are working to figure that out now, because it's that patient that didn't have access to transportation, didn't get their meds, and didn't understand perhaps that they needed to weigh themselves every day. And then they start getting sicker with their heart failure. That's the patient that ends up in the emergency department hospitalized. And it wasn't because the right meds weren't prescribed. It was because they didn't have access to go pick up their meds from the pharmacy, and they didn't have anybody around for social support, and they didn't understand the importance of weighing themselves, and they were getting more and more fluid retention and didn't even realize it. So the socioeconomic drivers, and some of you may have heard this before, but the socioeconomic drivers of risk are more than a 60% contributor to negative health outcomes. Some of the numbers I've seen are as high as 80%, which still to me is mind-boggling, but at least 60% of the risk to any individual patient are based upon the socioeconomic factors that are part of their everyday life. So we identify these individuals and the vulnerability that they have in order to help to identify and mitigate those risks. And you can see it in a different, you could see them again as high, moderate, or low. You could have a score or a percentile. And then this shows the reasons why that individual's at risk. So there's a lot more I could get into, but I want to pause here. I'm going to come off the presentation, and I'm going to invite some conversation. Any questions that you have around AI in healthcare in general, or how this could be translated to a prison population? And I recognize, I mean, some of the challenges here are very real. If you're still on paper, then you're not going to have a lot of electronic data to work with. In that environment, we are still able to get socioeconomic data, and you could get something in an electronically generated list in terms of delivering it to you. But obviously, there are a lot of challenges around who's going to use it and how do we have access to it if largely you're still on paper today. So is anybody in the correctional setting using any data or analytics of any sort on the roundtable here? And anybody, please feel free to speak up.
We're using lots of data. We do have an EHR, although it's not particularly robust, but as far as like predictive analytics and whatnot, I think that is, I would be surprised if that exists in corrections. It's certainly becoming more and more present in the civilian healthcare industry, but you know, one of the things that civilian EHRs and civilian data analysis has as an advantage is they have a lot of standards in place already. You know, they're conforming to a lot of CMS guidance and other industry standards. So their data is being mapped and gathered in the same way, in particular from claims data and billing data. You know, we don't bill anything, so we don't have claims data, we don't have billing data, and we don't have an industry set, you know, data dictionary or data collection standard or even EHR standards that everyone is using. So it makes it really hard for us all to get on the same page and get enough data aggregated to use an AI engine and that sort of thing.
That's a great point, to have some basic norms around. And there's a lot of clinicians on this call, and I really appreciate that. I can identify with that. I'm glad with the perspectives. But that said, if there's not a standard for how conditions are even identified, as you mentioned, like, and I'm not using an ICD-10 code necessarily in a setting where I'm not submitting a bill for anything, it's going to be hard to track and to even segment a population, won't it? What I see a question here. from Marianne, corrections is variable with respect to adoption of an electronic record. Is an electronic record actually required to manage a population? For instance, could we combine some of the data sources with gathered health factors to predict and prescribe? So in order to predict on a population with analytics, we wouldn't have to have an EMR. We'd have to have some basic data sources. Identifying information, and an analytics model could work with a pretty thin data set. Wouldn't have to be an electronic record. The more robust the data, the more you trust it, and the more variables you have to work with, the better in general a predictive model would be. So I'll say that, and that lends itself to coming from an electronic record then, but I think it's oversimplification to say electronic records can provide easily all the data we need. Many of them, it feels like the data is locked inside the EHR. And then even when it isn't and it's available, we find that it's documented in a variety of ways. To Quinn's point, there aren't necessarily good standards for even how documentation occurs within the electronic record. That's been a flaw in both design and how we've implemented. I've been implementing electronic records. I implemented dozens of them earlier in my career. And that's a flaw in how we implement it. We didn't require standardization. We're just trying to get people to use it. And that was a victory. But the variable use created less value than we would otherwise have liked to have gotten. And another question here, intervention outcomes. If you had high efficacy results when prescribing interventions, describe some of these scenarios of success. Yeah, I'll talk, let me just give a little bit of anecdote and example there. And again, this is not in the correctional setting, but I think to just inspire what could be done, I want to share what we've done and accomplished in healthcare a little more broadly. In identifying patients at risk for an avoidable admission, for example, we identify particular populations at risk. And let's take a group of diabetics, and then within that group of diabetics, we've identified, and this was with one health system, we identified a cohort within that would benefit particularly from a weight management program in order to prevent an admission in the next 30 days. Now, for anybody who knows diabetes, putting them in a weight management program and they lose 10 pounds, that by itself is not going to cause them to prevent that next admission to the hospital. I won't have a more controlled glycated hemoglobin in 30 days. My blood sugars might be slightly better controlled, but that's going to prevent the next hospitalization? Probably not. But when we dug a little deeper, getting them in a weight management program, it does several things. One, it creates social support. So now they may be more inspired or motivated to take care of themselves. The second thing that does is it creates a help chain. While they're in a support group and a weight management program, they may also be getting clues or insights into how I can better access help if I need it, rather than just showing up in the hospital. So some patients don't have that support and that help chain of what they do. If the first sign of trouble, they go to the emergency room. And so that was the driver for that small segment of the diabetic population to have reduced hospitalizations. Now, I'll give one more example. Now, this is at the individual level. This happened to also have been a diabetic in New York City, one of our customers. And the case manager was doing a home visit, and she said, I'm sorry, I'm kind of embarrassed. We're using this new tool, and it's asking us to ask about your diet. Now, this guy happened to be a pretty famous chef in New York City, and here the case manager is asking him about his diet. He's pretty overweight. And he turned to her and he said, what diet? And he opened his cupboard. It was all processed foods, like whatever, like mac and cheese or, Stouffer's in a box or something. And you go, my goodness. He's like, I don't have time to take care of myself. So I make all this gourmet food, come home and eat terrible. And it was very enlightening for that case manager to recognize artificial intelligence will tell us things that we didn't otherwise see about a patient. So AI, if it's really bringing value, is not always going to be intuitive. And honestly, it isn't always right either, but those are examples where it really pinpointed what the opportunity was. When we do, one last point, the proof is in the pudding. So we've published studies. If you start to evaluate artificial intelligence, you want to look at two things. One is the model performance, predictive model. Before I start using it, all you have to go on is either historical success, like a published study, or you have model performance. And so you look at it and the predictive values are good and whatnot. When you start using it, the proof is in having changed outcomes for a population of patients. It's a case control analysis. This population we acted on and their outcomes were this. This population we didn't act on and their outcomes were this. And we do those sorts of studies all the time. And the group, and if there's a difference between those two groups and you say, what was the cause of the difference between those two groups? Did we attribute that to the insights from this solution? Or was it that they had twice as many case managers working in that population, and that's why they had better outcomes? So you need to see and evaluate differences and then dig deeper and say, why were there differences in that population? If you can attribute it to the insights provided by AI, then you have something.
From my experience, the people that pay for AI, so senior administrations and leadership, the types that authorize the funding that these kinds of programs require, are looking for a substitute for clinicians, or a substitute for clinical involvement, and they get marketed that way. And I think these predictive modelings is an example for COVID-19 pandemic response, where they're like, well, we're going to rely on this model to make our decisions for us instead of clinical expertise. And I think those of us in the field are looking for AI to provide a decision support solution, another tool in the toolbox to help guide treatment management decisions and think about things that you would not have thought about otherwise in your limited short encounter where you're pressured to see multiple patients. And I think that the real promise is for AI to deliver clinical modeling at the individual level. You have a patient in the clinic, the AI engine runs all the diagnostics of all the data you have for that patient, says, look, there's a 20% likelihood they're going to have this, or a 30% likelihood they're going to have that. You might want to think about that. Those kinds of things, I think. And if a model is really mature, they totally work. I've used one and it was very effective.
Well, that's great, great perspective. And I honestly, this is the question nobody's asked yet, like in the next 5 to 10 years, probably will become more and more trusting and dependent on AI than we are today. Like a nav system. Has anybody got a navigation system in your car where not only does it tell you where to turn, like standard GPS, which I don't know anybody who doesn't trust that now. But if GPS started telling you to go down the wrong road, you'd stop trusting it. You'd pull out that paper map again, right? But then now these sophisticated nav systems also tell you they'll brake if you're getting too close to a car ahead of you, or my steering wheel, that's what that's called. It will vibrate, and I just have a 2014 Fusion, and it vibrates if I'm drifting into the next lane. So these AI systems in navigation, we've begun to learn and develop a trust in. The same will be true in healthcare, probably more than 5 years out, but it will get to a point where I trust what it's saying, and it's seeing the patient holistically, and hey, think about this. And there's this patient's at risk for this, and it's going to get more and more both precise and also actionable. Like, do this, think about this. And really, I would say advise us, replace clinicians in my career. But someone else have a comment?
Yeah, in the area of utilization, I think it could be very, very helpful. In our agency, we're just getting started with having a utilization management program, and really looking at and figuring out, looking at claims data, if the money that's being spent on it's taxpayer money, and really looking at, is there fraud, waste, and abuse? What is predictive? Can we shave off? Can we predict next year's budgets based on prior year's budgets, based on population numbers, based on, and on down the line? And so there's a lot of, and then just looking at length of stays when you're trying to reduce cost. And, that's how they utilize a lot of that data, is what is the typical length of stay per CMS, and so on and so forth. And it really has a place in our future, and we have got to do better, especially in these government programs, because a lot of this is taxpayer money funded, or, you know, whether it's on a state level or whether it's on a federal level, we've got to be more accountable. And the resistance, I don't understand the resistance of not having electronic healthcare records. It's ridiculous when the private sector and everybody else had to have it, you know, way back. Why hasn't this section of healthcare been required to move into that realm? It's when you really start looking at the why to that, it really comes down to those big companies, and, you know, they think that they're on the front end, it's a big cost, but no, it's a big cost on the back end by not doing it.
It really is, but a lot of clinicians too have experienced in the public sector the hardship of having to document in a way, you know, electronically, that's frustrating. So this is an opportunity to say, hey, if we're going to go electronic, let's make sure we're getting value. We actually need clinicians to be more efficient, not less efficient, because we went to electronic. And that would be a good priority if anybody is deploying electronic health records in the setting that's still on paper, like in the correctional systems. There was another comment here from Leanza. Interesting. Yeah, the prison has a reoffending queue analysis on the security side. Wouldn't it be great as the lines blur? And maybe I'm oversimplifying this. Forgive me if I am, feel free to correct me, but as the lines blur between folks that are in the community and have been released from prison and those that haven't yet committed a crime but are going to end up in prison, wouldn't it be great if we could understand what those socioeconomic factors are and driving the risk, or mental health factors driving the risk for a patient, and prevent that? I mean, wouldn't we consider incarceration almost like a harm event? That if we could help them ahead of time, practice some preventative medicine, and have the insights to do something specific, and that person ends up on a better path and never ends up in jail, not because they committed a crime and didn't get caught, but actually went on a different path, got treatment for the mental health because this patient was identified as particularly at risk. So, and we do, the question here is, are there AI engines looking at behavioral health? We do have a number of products in the behavioral health space. Patients at risk for depression and self-harm and opioid abuse are certainly hot topics in the country, and we've got use cases there, and other companies do too. So there is work in mental health where AI is concerned. Any other thoughts or questions? I feel like I talked too long, but I wanted to get some good discussion here, and we got a couple minutes left. I see a question from Jeanette. The best time to consider incorporating AI products when thinking about an EMR? You know, that's a very variable answer. I would just say this: don't feel that data limitations are a barrier to considering AI. There are options to using AI even with very limited data. So I wouldn't, pardon the pun, I wouldn't let yourself be handcuffed by the sense that we don't have enough data. So we haven't gotten to electronic record yet, or we can only do this after we've been live for 2 years and now we can think about AI. Don't limit yourself like that. There are options, and with the social vulnerability type insights that I shared with you that we're doing, doesn't need any clinical data to understand socioeconomic risk to patients. Now, obviously, with inside the four walls of a facility, those socioeconomic factors are very much modified to their day in and day out routines and you know what's provided to them. So they're more of a defined socioeconomic set of features about those patients at that point.
I will say, though, that having worked with an electronic health record within the detention environment, for me, when I was a health service administrator, I was totally able to justify expanding, like, and hiring more providers, because I could show how many visits, what were the visit types, what were the needs were, et cetera. We expanded our mental health department, you know, what we're being asked to do by NCCHC standards and other standards versus what the companies say you should be able to handle and staff with, the two don't match. And so then I could show via, you know, all the information from within the EHR, I could show, no, do the math. They don't equal. If you want me to meet the standards, I need this much staffing. If you want me, you know, so there's so many benefits to having an EHR just besides, but you do have to make it user-friendly, provider-friendly, so that those visits can occur timely, et cetera, just as you said. But using data, you know, knowing what really is happening and having a way to look at that analytically is priceless.
And that's a great way to put a bow on our conversation here today. Is not every setting is ready for AI tomorrow, but be data driven as a passion in how you carry a conversation or how you promote something. Be data driven, and AI is an enabler if you have a data driven culture. So if you all are involved in driving to a data driven culture, AI will become more and more not only prevalent but also valued. And I've been using the term AI a lot. Quinn asks, used it, just give there are a whole lot of different definitions, but when I talked about the level of sophistication of prescriptive analytics, about what should we do next, that's data science with the power of machine learning around it. That's a good example of artificial intelligence that says, okay, here's something more than the mind can imagine or come up with on our own. It takes pretty high-powered computing to do that. I think we're at time, and unless I'm mistaken, our session is now ending, and I want to thank everybody for your participation. Really enjoyed it, and I learned from you all as well. I will go ahead and get the slide deck. I'll have to find out how from the support team, but get it posted to the website and share the slide deck. Absolutely. Thanks everyone for your time and participation.